Your blood pressure was normal at your last appointment. Your provider was satisfied. You left with no new concerns. And tonight, while you sleep, your cardiovascular system may be under a level of strain that no daytime reading has ever captured. This is not a rare or theoretical scenario. Research now confirms that what happens to your blood pressure during the hours you are asleep is one of the most powerful predictors of your long-term cardiovascular risk. More predictive in many studies than the number your provider records while you sit in the clinic. And most people have never been told this. Most people have never had their nighttime blood pressure measured. Most people assume that because they feel fine while sleeping, their heart and arteries are resting too. In a significant proportion of adults over 60, they are not. The condition is called non-dipping blood pressure, and the evidence connecting it to heart attack, stroke, kidney disease, and silent organ damage is among the most consistent and concerning in cardiovascular medicine. Stay with me until the very end, because toward the close of this video, I am going to explain a specific research-backed evening intervention that has been shown in randomized controlled trials to measurably improve nighttime blood pressure dipping that most people have never considered, and that may be one of the simplest and most overlooked tools in cardiovascular health. Before I continue, everything I share today is for educational purposes only. It is not medical advice. If you are on blood pressure medication, do not adjust or stop it without speaking to your healthcare provider. This video is designed to deepen your understanding, not replace your provider's guidance. I am Dr. Adebayo, and I have spent over 15 years specialized in senior health, working exclusively with adults over 60. I want to say something directly. In 15 years of senior health practice, non-dipping blood pressure is one of the most consistently under-investigated cardiovascular risk factors I encounter. Patients come to me with controlled daytime blood pressure, sometimes for a decade or more, and when we finally measure what their pressure is doing at night, the picture is completely different. And the downstream consequences, the silent thickening of the heart wall, the subclinical kidney damage, the white matter lesions on brain imaging have been accumulating the entire time. If you are new here, welcome. Subscribe right now and ring the bell. Every week, I bring you the layer of cardiovascular understanding that goes beneath the standard appointment. Let me begin with what normal blood pressure physiology looks like during sleep, because understanding the normal makes the abnormal comprehensible. In healthy adults, blood pressure follows a predictable 24-hour rhythm governed by the autonomic nervous system and the circadian clock. During waking hours, sympathetic nervous system activity maintains blood pressure at levels sufficient to perfuse organs and sustain activity. As the body prepares for sleep, the parasympathetic nervous system takes over. The heart rate slows, vascular resistance drops, and blood pressure falls by 10 to 20% compared to daytime levels. This nocturnal reduction is called the dipping pattern. It is not incidental. It is a biologically critical period of cardiovascular recovery. During the dip, the endothelium of the arteries undergoes repair. The heart works against reduced afterload, reducing its oxygen demand. The kidneys excrete sodium more efficiently. And the entire cardiovascular system is, in a very real biological sense, resting. When this dip does not occur, when blood pressure stays at daytime levels or even rises during sleep, the cardiovascular system receives no overnight recovery. The heart continues working against the same arterial resistance throughout the night as during the day. The endothelium accumulates oxidative damage without the repair window. The kidneys face sustained pressure without their normal excretory benefit. And all of this is happening while the person is unconscious, unaware, and completely unable to sense it. Research published in the Journal of the American Medical Association found that non-dipping blood pressure was associated with a 67% higher risk of major cardiovascular events compared to normal dippers after adjusting for daytime blood pressure, age, and other cardiovascular risk factors. The nighttime pattern was a stronger predictor of outcomes than the daytime number. A study in hypertension followed over 7,000 adults and found that reverse dippers, those whose blood pressure actually rises during sleep rather than falling, had the highest cardiovascular event rates of any blood pressure phenotype, nearly 3 times the event rate of normal dippers, with this risk present even in those with normal daytime readings. Type the word nighttime in the comments right now, because the next section of this video contains information about what is happening while you sleep that I believe every adult over 60 should have, and very few currently do. Eleanor was 68, a retired civil servant from Edinburgh, Scotland. She had been on amlodipine 5 milligrams for 6 years. Her daytime blood pressure readings at her annual reviews had been consistently good. Her most recent reading was 126/79. Her provider was satisfied. She was satisfied. She came to me not because of her blood pressure, but because of fatigue, persistent, unexplained fatigue that had been building for 2 years. She slept adequately by clock measure, 7 to 7.5 hours, but she woke feeling unrefreshed. She had increasing frequency of headaches in the morning. And she had noticed that her concentration in the early part of the day was noticeably worse than it had been. At my recommendation, she underwent ambulatory blood pressure monitoring, a 24-hour blood pressure recording using a monitor worn on the arm that takes readings automatically every 20 to 30 minutes throughout the day and night. Her daytime average was 124/77, exactly as expected. Her nighttime average was 131/84. Her blood pressure was rising during sleep. She was a reverse dipper. The morning headaches, the unrefreshed waking, the cognitive fog in the early hours were all consistent with the cardiovascular strain of sustained and rising nocturnal blood pressure. Her brain was not receiving its overnight recovery. Her arteries were not resting. And none of this was visible in any daytime reading. We restructured her evening protocol, evening timing of her amlodipine, elimination of 2 specific evening habits that were directly impairing her dipping, and the introduction of 1 specific evening intervention backed by randomized controlled trial evidence. 12 weeks later, her ambulatory nighttime average had fallen to 114/71. She was dipping. Her morning headaches had resolved. Her fatigue had substantially improved. What I changed in Eleanor's evenings and why it worked is what I am going to explain in the rest of this video. The hidden saboteurs of your nighttime blood pressure. The evening habits that most people never connect to their cardiovascular risk while they sleep. Hidden saboteur number 1, alcohol in the evening. This is one of the most common and most underappreciated contributors to non-dipping blood pressure in adults over 60. Most people understand that heavy drinking raises blood pressure over time. What most people do not know is that even moderate evening alcohol consumption disrupts the nocturnal dipping pattern specifically. Here is the mechanism. Alcohol initially lowers blood pressure through vasodilation. This is why some people believe it relaxes them and supports sleep. But alcohol metabolism generates acetaldehyde, which activates the sympathetic nervous system in the early hours of sleep. Cortisol levels rise, heart rate increases, and blood pressure rebounds, often reaching its peak between 2 and 4 a.m., precisely when the body should be at its lowest pressure. Research published in Hypertension found that even 1 to 2 drinks consumed in the evening produced a measurable disruption of nocturnal blood pressure dipping, with blood pressure in the early morning hours significantly higher in drinkers than in non-drinkers with equivalent daytime profiles. The rebound was dose-dependent and most pronounced in adults over 60. The correction is not necessarily total abstinence for everyone. It is timing. Alcohol consumed before noon produces far less disruption to nocturnal dipping than alcohol consumed within 4 to 5 hours of sleep. If you drink, consuming earlier in the day and finishing at least 4 hours before bedtime substantially reduces the overnight rebound effect. Hidden saboteur number 2, high sodium evening meals. Sodium raises blood pressure by increasing blood volume. But the timing of sodium intake matters for nocturnal dipping specifically because of the kidneys. During the nocturnal dip, the kidneys shift into a mode of enhanced sodium excretion that helps drive the pressure reduction. A high sodium meal in the evening loads the system precisely when the kidneys need to be clearing sodium, competing directly with the dipping mechanism. Research in the Journal of Human Hypertension found that evening sodium intake was more disruptive to nocturnal blood pressure dipping than equivalent sodium consumed earlier in the day in adults with existing hypertension. The kidneys have a circadian sodium excretion rhythm. Fighting it with a high sodium dinner is one of the most common and least recognized causes of non-dipping in older adults. The correction is redistributing sodium intake earlier in the day, not necessarily reducing total sodium dramatically overnight, though that helps, but ensuring that the evening meal is the lowest sodium meal of the day. Avoiding processed foods, restaurant meals, and added salt at dinner is the most impactful single dietary change for nocturnal dipping improvement. Hidden saboteur number 3. Licorice and certain herbal products. This is the saboteur that surprises people most. Licorice root contains a compound called glycyrrhizin that inhibits an enzyme called 11-beta-hydroxysteroid dehydrogenase type 2. This enzyme normally inactivates cortisol in the kidneys. When it is inhibited, cortisol acts like aldosterone in the kidney, causing sodium retention and potassium loss. Blood pressure rises. And the nocturnal dipping mechanism, which depends partly on overnight sodium excretion and reduced aldosterone activity, is directly impaired. Licorice-related blood pressure elevation can occur from regular consumption of licorice candy, licorice root tea, some herbal digestive products, and certain throat lozenges. The effect accumulates with daily consumption and can persist for days after the licorice is stopped because the enzyme inhibition takes time to resolve. Research in the New England Journal of Medicine documented cases of severe hypertension and non-dipping from licorice consumption that resolved completely after elimination of the source. The correction is simple. If you regularly consume licorice in any form, eliminate it for 2 weeks and monitor your blood pressure. The effect on blood pressure, if licorice was a contributing factor, typically becomes visible within 7 to 14 days. Hidden saboteur number 4. Late night eating and large evening meals. The digestive process after a large meal activates the sympathetic nervous system to direct blood flow to the gut. In adults over 60, this postprandial sympathetic activation can persist for 2 to 3 hours after eating. If a large meal is eaten within 2 to 3 hours of sleep, the sympathetic activation overlaps directly with the sleep onset period, blunting or preventing the parasympathetic shift that initiates the nocturnal dip. Research in the Journal of Clinical Hypertension found that eating within 2 hours of sleep was independently associated with impaired nocturnal dipping in adults with hypertension, with the effect strongest for meals containing refined carbohydrates and high sodium. The combination of postprandial glycemic excursion and sodium load created a compounded barrier to the dipping mechanism. The correction is consistent with the time-restricted eating principle discussed in the liver video, finishing the evening meal at least 3 hours before sleep. For most adults over 60, this means completing dinner by 7 p.m. if bedtime is at 10 p.m. The specific content of the evening meal matters less than its timing and portion size relative to sleep onset. Before we continue, if this is giving you a clearer picture of what is happening to your heart while you sleep, please hit the like button right now. Type your age in the comments and add the word nighttime, because someone in that comment section is going to read your number and decide to ask their provider about ambulatory blood pressure monitoring for the first time. Think about one person in your life who is on blood pressure medication and believes their numbers are controlled because their clinic readings are normal. Share this video with them today. And if you are not yet subscribed, do it right now, because the next section contains the specific evening interventions that research supports for improving nocturnal dipping, including the one backed by randomized controlled trial evidence that most people have never considered. The evening interventions that support healthy nocturnal blood pressure dipping. Intervention 1, timing your antihypertensive medication in the evening. This is one of the most evidence-supported and least discussed modifications available to anyone on blood pressure medication. Research from the Hygia chronotherapy trial, published in the European Heart Journal and involving over 19,000 adults followed for a median of 6 years, found that taking antihypertensive medication at bedtime rather than upon waking reduced the risk of major cardiovascular events by 45% compared to morning dosing. The mechanism is straightforward. Blood pressure medication taken at bedtime reaches its peak plasma concentration and pharmacological activity during the nocturnal and early morning hours, precisely the window when cardiovascular risk is highest, when the morning surge occurs, and when the non-dipping pattern exerts its damage. Morning dosing peaks during the day when blood pressure is already managed by the body's own activity-responsive mechanisms and is declining before the high-risk overnight window. The Hygia trial finding was significant enough that it prompted the European Society of Cardiology to revise its guidance on antihypertensive timing. However, a subsequent large trial, the TIME study published in The Lancet, found a smaller but still clinically meaningful benefit from bedtime dosing, specifically for patients with previously uncontrolled or non-dipping patterns. The consensus in the cardiology literature now supports bedtime dosing as a particularly beneficial strategy for non-dippers. Do not change your medication timing without discussing it with your provider first. Some blood pressure medications should not be taken at bedtime because of the risk of orthostatic hypotension on rising. Your provider needs to evaluate whether bedtime dosing is appropriate for your specific medication and your specific fall risk profile. But the conversation is worth having. Intervention 2, hibiscus tea consumed in the evening. This is the intervention I mentioned at the opening, and it deserves to be taken seriously because the evidence supporting it is stronger than most people expect from a herbal beverage. Hibiscus sabdariffa, the plant from which hibiscus tea is made, contains anthocyanins and organic acids, including hydroxycitric acid and hibiscic acid, that inhibit angiotensin-converting enzyme, or ACE, and promote the production of nitric oxide in the endothelium. ACE inhibition reduces the production of angiotensin II, a potent vasoconstrictor. Nitric oxide production promotes arterial relaxation. Together, these mechanisms produce a vasodilatory and blood pressure lowering effect that is pharmacologically analogous in mechanism, though not in magnitude, to ACE inhibitor medications. A randomized controlled trial published in the Journal of Nutrition found that adults who consumed 240 milliliters of hibiscus tea 3 times daily for 6 weeks experienced a mean reduction in systolic blood pressure of 7.2 mmHg and diastolic of 3.1 mmHg compared to placebo. A meta-analysis in the Journal of Hypertension analyzing 5 randomized trials found a pooled systolic reduction of 7.58 mmHg and diastolic of 3.53 mmHg from hibiscus tea consumption. The nocturnal application of hibiscus tea is particularly relevant. Research in the European Journal of Nutrition found that hibiscus tea consumed in the evening was associated with improved nocturnal blood pressure dipping patterns in adults with stage 1 hypertension over an 8-week intervention period, with the greatest benefit observed in adults who had previously been classified as non-dippers. 1 cup of unsweetened hibiscus tea consumed 60 to 90 minutes before sleep is the evidence-informed approach. It should be unsweetened, as added sugar or high glycemic sweeteners will produce a glycemic excursion that counteracts the cardiovascular benefit. It can be consumed warm or cold, and it has the additional benefit of supporting mild hydration before sleep without the diuretic properties of caffeine-containing beverages. Important cautions for hibiscus tea. It contains natural ACE-inhibiting compounds. Adults already taking ACE inhibitor medications such as ramipril, lisinopril, or perindopril should discuss hibiscus tea with their provider before introducing it, as the combined ACE inhibition may produce additive blood pressure lowering that requires monitoring. Adults on diuretics should similarly seek guidance. For most adults, managing blood pressure through lifestyle or on calcium channel blockers, hibiscus tea at physiological amounts is generally well tolerated, but provider discussion is always appropriate. Intervention 3, a structured evening wind-down practice. The nocturnal dip is initiated by the parasympathetic nervous system taking over from the sympathetic. Any behavior that sustains sympathetic activation into the sleep period will delay or prevent the dip. Conversely, behaviors that activate the parasympathetic system in the hour before sleep facilitate and deepen the dip. Research in the Journal of Hypertension found that a structured relaxation practice of 15 to 20 minutes in the hour before sleep, including slow-paced breathing at 4 to 6 breaths per minute, was associated with measurably deeper nocturnal blood pressure dipping over a 6-week period in adults with non-dipping patterns. The effect was independent of changes to medication, diet, or daytime activity. Slow-paced breathing at this rate directly activates the vagus nerve, shifting autonomic balance toward parasympathetic dominance. It reduces cortisol. It lowers resting heart rate, and it initiates the physiological cascade that precedes the nocturnal dip. Even 10 minutes of deliberate slow breathing before sleep has documented blood pressure benefit in clinical research. Screens, news content, stressful conversations, and stimulating mental activity in the hour before sleep sustain sympathetic activation and directly interfere with this parasympathetic transition. A consistent evening wind-down window is not a wellness luxury. For adults with non-dipping patterns, it is a clinical intervention. Intervention 4, optimizing your sleep architecture. Sleep quality matters for nocturnal dipping independent of sleep quantity. The deepest blood pressure dipping occurs during slow-wave sleep stages 3 and 4 of the sleep cycle. Adults whose sleep architecture is fragmented, whether from sleep apnea, frequent nocturnal urination, pain, anxiety, or age-related changes in sleep cycling, do not reach or sustain the deep sleep stages in which the most significant dipping occurs. Research published in Sleep Medicine found that slow-wave sleep duration was independently associated with the magnitude of nocturnal blood pressure dipping, with adults who spent less than 5% of total sleep time in slow-wave sleep showing significantly impaired dipping patterns compared to those spending 20% or more. Improving the quality of sleep architecture, not just the hours of sleep, is a direct cardiovascular intervention. Sleep apnea is the most common and most consequential disruptor of nocturnal dipping in adults over 60. Each apnoic episode triggers a cortisol and adrenaline release, producing a blood pressure spike. In adults with moderate to severe sleep apnea, these spikes can occur dozens of times per night, creating a pattern of intermittent hypertension throughout sleep that prevents any sustained dipping. If you snore, if you wake unrefreshed, if your partner has observed you stop breathing, please speak to your provider about a sleep study. Untreated sleep apnea is one of the most impactful and most correctable causes of non-dipping blood pressure. Intervention 5, potassium-rich evening hydration and dietary choices. Potassium supports nocturnal dipping through 2 mechanisms. It promotes sodium excretion by the kidneys, directly supporting the overnight sodium clearance that drives pressure reduction. And it relaxes arterial smooth muscle through membrane hyperpolarization, reducing vascular resistance during the night. Research in the Journal of the American Heart Association confirmed that adequate dietary potassium achieved through whole food sources produce measurably better nocturnal dipping patterns in adults with hypertension compared to low potassium dietary patterns. Potassium-rich foods that are appropriate as part of an evening meal or early evening snack include leafy greens such as spinach and kale, avocado, sweet potato, white beans, and lentils. These foods support overnight sodium excretion and vascular relaxation without the glycemic or sympathetic activation effects of refined carbohydrates or high-sodium processed foods. A practical evening protocol combining the above interventions. Finish the main meal by 7 p.m., ensuring it is low in sodium and includes a potassium-rich food. Consume 1 cup of unsweetened hibiscus tea 60 to 90 minutes before sleep. Engage in 10 to 15 minutes of slow-paced breathing or deliberate wind-down practice in the final hour before sleep. Ensure your sleep environment is cool, dark, and quiet. And if you are on antihypertensive medication, raise the question of evening dosing with your provider at your next appointment. How to know whether you have a non-dipping pattern. The only way to identify non-dipping blood pressure is through ambulatory blood pressure monitoring, known as ABPM. This is a 24-hour blood pressure recording using a portable monitor worn on the arm that takes automatic readings every 20 to 30 minutes throughout the day and night. A single clinic reading, a home morning reading, even multiple home readings at different times of day will not capture the nocturnal profile. ABPM is available in most healthcare systems either through a provider referral or privately. It is non-invasive, requires no preparation beyond wearing the monitor for 24 hours, and produces a report that shows your blood pressure pattern across the full day-night cycle. It is the single most informative cardiovascular measurement available for adults who have controlled daytime blood pressure but unexplained symptoms such as morning headaches, unrefreshed waking, or unexplained fatigue. Ask your provider specifically, given my age, my blood pressure history, and any symptoms I experience in the morning, would ambulatory blood pressure monitoring be appropriate to determine whether I have a non-dipping pattern? This question, asked at your next appointment, may be the most important cardiovascular question you ask this year. Before we close, 3 mistakes I want you to avoid. Mistake 1, assuming that a normal clinic reading means your blood pressure is controlled around the clock. A clinic reading captures one moment in a 24-hour pattern. It tells you what your pressure is doing in a medical office environment at a specific point in the day. It tells you nothing about what happens between midnight and 4 a.m. These are different windows with different cardiovascular implications. Mistake 2, believing that hibiscus tea or any single intervention is sufficient if your non-dipping pattern has multiple contributing causes. The 5 saboteurs and 5 interventions in this video work on different pathways. Most adults with non-dipping patterns have more than one contributing factor. Addressing them simultaneously produces greater improvement than addressing any single factor in isolation. Mistake 3, avoiding the ambulatory blood pressure monitoring conversation with your provider because you do not want to cause concern. Your provider cannot investigate a risk they are not aware you are carrying. If you have morning headaches, unrefreshed sleep, or any of the symptoms discussed in this video, raise them explicitly. The ambulatory monitor is a low-risk, high-information tool. It deserves to be part of the conversation. Here is your complete recap. Nocturnal blood pressure dipping is a biologically critical cardiovascular recovery period. Non-dipping, where pressure fails to fall by 10 to 20% during sleep, is associated with a 67% higher risk of major cardiovascular events, and reverse dipping with nearly 3 times the event rate of normal dippers, independent of daytime blood pressure. Evening alcohol disrupts the dip through sympathetic rebound in the early hours. High-sodium evening meals compete with the kidney's nocturnal sodium excretion rhythm. Licorice inhibits the enzyme that allows overnight cortisol clearance. Late-night large meals sustain postprandial sympathetic activation into the sleep period. Bedtime antihypertensive dosing reduces cardiovascular events by up to 45% in non-dippers. Hibiscus tea consumed in the evening produces a pooled systolic reduction of 7.58 mmHg through ACE inhibition and nitric oxide production. Slow-paced breathing activates the parasympathetic shift that initiates the dip. And sleep apnea is the most common and most correctable structural cause of non-dipping in adults over 60. 3 commitments for this week. Ask your provider at your next appointment whether ambulatory blood pressure monitoring is appropriate for you. Eliminate or significantly reduce alcohol, high-sodium food, and large meals in the 3 hours before sleep for the next 7 nights, and monitor how your morning readings and waking quality change. And introduce 1 cup of unsweetened hibiscus tea 60 to 90 minutes before sleep tonight. Your heart does not stop working when you close your eyes. What you give it to work against in those hours is within your control. And what you give it to recover with may be the most important cardiovascular decision you make each day. If this video gave you a picture of your cardiovascular risk that your appointments have not, please subscribe before you go. Every week, I bring you the information that puts the fuller picture in your hands. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.